The second lecture of module, Geriatric Anesthesia, is on perioperative management of geriatric patients. In this lecture, we will discuss preoperative assessment of geriatric patients, as well as intra and post-operative management of these patients posted for surgery under anesthesia. Preoperative assessment is covered under following headings. So, what should be our goals while assessing elderly patients during pre-anesthetic checkup? As we have discussed in last lecture, that these patients have various age-related physiopathological changes. Keeping that in mind, our primary goal is to identify those risk factors. Moreover, we should try and optimize at least modifiable risk factors before taking them to surgery. Pre-op risk stratification is very important in these patients to plan degree of post-operative care, like which patient needs HDU or ICU care, need of post-operative mechanical ventilation, and in some circumstances need to plan about end-of-life care. Even post-discharge planning, like level of care required at home, about pain management, or need of palliative care should also be discussed during pre-operative visit. Ideally, multidisciplinary approach is needed at this stage, which includes not only anesthesiologist and surgeon, but also involve physician, geriatricians, physiotherapist, and maybe psychologist. Starting with history, it is very important to elicit detailed clinical history in these patients. Here, I will be discussing some geriatric focus points pertaining to medical and surgical history. Older adults have proportionally the highest number of medical comorbidities. In fact, patients over the age of 65 have average 3 to 4 more medical comorbidities than a younger counterpart. So, an elaborative history of various comorbid conditions assessing different organ systems should be elicited in these patients. The incidence of cardiovascular complications is higher in geriatric patients. Patients with history of cardiovascular pathology posted for non-cardiac surgery should be evaluated as per ACC/AHA guidelines. The revised cardiac risk index is most commonly used to predict post-operative complications after major non-cardiac surgery. It is important to assess exercise tolerance or functional reserve, as most of the geriatric patients have decreased functional reserve and a reduced ability to compensate for physiologic stressors such as surgery. These patients are also at increased risk of perioperative pulmonary complication because of increased incidence of both obstructive and restrictive lung disease with age. Hence, the basic preoperative pulmonary assessment is the key component to stratify risk as well as to optimize these patients. Risk factors like history of COPD, chronic smoking, or history of obstructive sleep apnea should be evaluated in detail. Like in obese patient, OSA can be screened with the help of stop bang, ASA, or with the help of Berlin questioning. Difficult mask ventilation is anticipated in patients with history of OSA. Polypharmacy is a major concern in elderly patients because of potential adverse drug interactions with each other and also with anesthetic drugs. It is also associated with adverse health outcomes, including falls, increased length of hospital stay, readmissions, mortality, and functional impairment because of its side effects on various organ systems. The alcohol use can be screened by a modified gauge questionnaire, which has been validated for use in older adults. Alcohol abuse associated with increased risk of pneumonia, sepsis, wound infection and disruption, and prolonged length of stay. Supplementation of folic acid and thiamine should be considered as preoperative prophylaxis for alcohol withdrawal syndromes. The incidence of depression in older population is about 11%. It can be easily assessed during pre-anesthetic checkup with the help of patient health questionnaire tool, which asks, in the past 12 months, have you ever had a time when you felt sad, blue, depressed, or down for most of the time for at least 2 weeks? Or in the past 12 months, have you ever had a time lasting at least 2 weeks when you didn't care about the things you usually cared about, or when you didn't enjoy the things that you usually enjoy? And if the answer is yes to any of the questions, it indicates that patient need further evaluation before taking to surgery. It is important to assess and optimize patients with depression because it predisposes them to postoperative cognitive dysfunction, in-hospital delirium, major adverse cardiac events, increased postoperative analgesic use, and suboptimal postoperative outcomes. The presence of dentures, hearing aids, spectacles, implanted devices like pacemakers should also be recorded in pre-anesthetic record chart. A detailed surgical history is also equally important because for patients, both CABG patients or patients with cardiac stenting might be on antiplatelet therapy. Previous spine surgery and fixation may cause administration of neuraxial anesthesia difficult in elderly patients with already compromised spinal anatomy. History of transplant surgery should also be ruled out as it has its own anesthetic implications. Malignancies are common in these patients, so history of radiotherapy or chemotherapy should be taken. In elderly females operated for CA breast, care should be taken to avoid IV cannulation and BP monitoring in ipsilateral limb. Apart from routine physical examination, comprehensive geriatric assessment is required in these patients. It includes cognitive and delirium risk assessment, assessment of functional and nutritional status, and also assessment of degree of mobility and frailty index. First is cognitive assessment. The various cognitive screening tools are the Mini-Cog test, verbal fluency test, Montreal cognitive assessment, cognitive disorder examination, and mini mental state examination. Out of these, the most efficient tool to screen preoperative cognitive impairment is Mini-Cog test. It consists of a 3-item recall test and clock draw test, which involves 3 simple steps. In step 1, the patient is asked to remember 3 commonly used words, and then patient is asked to draw a clock, after which patient should be asked to repeat those 3 words as given in step 1. Cognitive impairment are considered in those patients who are not able to recollect any of these words or can recall 1 or 2 words but not able to draw clock properly. But why is it so important to assess cognitive impairment preoperatively? It is because patients with mild cognitive impairment may have a critical impact on decision-making capacity. Even information regarding medication and functional status may be unreliable. Moreover, Preoperative cognitive impairment is one of the strongest predictors of postoperative delirium. It also predicts postoperative complications, functional decline, and death after surgery. There are several indices to assess delirium risk prediction indices, and most of these indices include age, cognitive status before surgery, some index of medical illness, and invasive nature of the surgery. The two validated risk prediction models for prediction of post-operative delirium are Rudolph and colleagues model for cardiac surgery and Marcantonio and colleagues model for non-cardiac surgery. Moreover, frailty and preoperative cognitive impairment are two independent risk factors associated with postoperative delirium. Next is functional assessment. It can be assessed by assessing activities of daily living or by assessing instrumental activities of daily living. Activities of daily living assesses the ability to perform basic tasks of self-care such as dressing, bathing, toileting, movement, continence, eating, whereas instrumental activities of daily living determines an individual's ability to live independently by the ability to complete shopping, laundry, transportation, finances, medications, food preparation, and housekeeping. Additional functional vulnerabilities should also be assessed routinely, like determination of vision defects, hearing defects, and solving difficulties. Patients with preoperative functional decline are associated with increased incidence of postoperative morbidity, mortality, and loss of function. After functional assessment, how can we screen mobility impairment? It can be assessed by inquiring about a history of falls, determining fall risk, and performing a tuck test. That is the timed up and go test. It is a very simple test. It involves timing patients while they perform the following tasks in sequence. That is, stand up from a chair without using armrest if possible, walk 10 feet, turn around, walk back to chair, and sit down on the chair. If time required to perform this task is more than 15 seconds, then it indicates that there is increased risk of fall, postoperative complications, and 1-year mortality. Next is nutritional status. It can be assessed by measuring BMI and serum albumin levels. If BMI is less than 18.5 kg per meter square and serum albumin concentration less than 30 gram per deciliter, places an individual at elevated risk. Even unintentional weight loss exceeding 10 to 15% of baseline weight within the prior 6 months is also associated with severe nutritional risk. Those patients with severe malnutritional deficit should be referred to dietitian for formal assessment, while pre-nutritional supplementation and counseling should be started in other patients. Why optimization of nutritional status is so important? It is because poor nutritional status are related to infectious complications like surgical site infections, pneumonia, urinary tract infections. And also risk of wound dehiscence and anastomotic leaks are more. Post-operative length of stay may also increase in poorly nourished patients. Coming to frailty. It is the most important parameter to be assessed in geriatric patients. It is defined as age-related decrease in physiologic reserve, resulting in increased susceptibility to stressors such as surgery and anesthesia. Frailty has been seen in 25 to 56% of older patients posted for surgery and in 10% in community dwelling elders. Linda Fried was the first to use a validated scoring system to define frailty. Frailty has been conceptualized in two major ways. First is the frailty phenotype or the Fried index, and the other is the deficit accumulation model or the frailty index. Fried index includes decreased reserve to physiologic stress and is characterized by decline across organ systems, whereas frailty index, as the name suggests, deficit accumulation model, is the accumulation of comorbid states that can result in overall physiologic vulnerability. The Fried phenotype is the best known of the clinical evaluation and consists of five criteria. These are unintentional weight loss, that is more than 10 pounds in past year, self-reported exhaustion, weakness assessed by decreased grip strength, slow walking speed, that is patient takes more than 5 seconds to walk 4 meter, and no physical activity. 1 point is assigned to each of these 5 criteria, and patients with 4 to 5 points are considered to be frail. This scale is validated and has shown good prognostic value. To assess frailty index, a list of symptoms, signs, diseases, and disabilities are surveyed and scored in a binomial fashion, that is yes and no. And then the fraction of the positive deficits from the total number surveyed is calculated. For example, 10 positive out of 40 surveyed equals a frailty index of 0.25. Frailty index is more complex to assess as it includes clinical features of all comorbidities. There are several other validated frailty screening tools available like Minicog, Score, Dark Test, Activities of Daily Living Dependence. This is what we have already discussed. Others are Charlson Comorbidity Index, Edmonton Frail Scale. Single frailty scores have no predictive value for morbidity and mortality. So why nowadays a lot of stress being given to screen frail patients? Basically, preoperative frailty assessment helps to improve and predict surgical outcomes. We can improve surgical outcomes by optimizing various modifiable factors. For example, rehabilitation programs like exercise, physiotherapy, strengthening programs, and nutritional support can be initiated preoperatively. Frail patients at risk of delirium may benefit from multidisciplinary interventions to support orientation, early mobilization, and maintenance of sleep-wake cycles. Moreover, utilization of palliative care consults to improve frail patients' outcome should be considered. As I said, it also predicts surgical outcomes like postoperative complications, length of hospital stay, readmissions rate within 30 days, and mortality rate. However, assessment of frailty requires special training and equipment. Moreover, input of lot of lab values and clinical data is required. And also it takes fair amount of time to complete these tests. Next is assessment of airway. The airway of geriatric patients are generally considered to be difficult because of age-related physiopathological changes. The age-related arthritic changes in head and neck and temporomandibular joint is a concern for anesthesiologists. Hence, range of motion of neck, especially extension and flexion, should be assessed by simply asking the patient to look at the ceiling, followed by touching chin to the chest. It can also be assessed with the help of goniometer. Mouth opening or interincisor gap should be assessed to rule out involvement of temporomandibular joint. Moreover, upper lip bite test or upper lip catch test in edentulous patients assesses the range and freedom of mandibular movement as well as the architecture of teeth. Fibrosis of oral mucosa with age can also decrease mouth opening. Next, dentition should be examined very cautiously in elderly patients. Many times, it is difficult to intubate trachea in patients with loose, missing or bucked teeth, even if Carmack-Lehane grading is 1. However, easy intubations are expected in edentulous patients, but at the same time, it is difficult to ventilate edentulous patients as it is difficult to achieve good face mask safely. The other risk factors associated with different comorbidities should also be assessed case-to-case basis, like patients with chronic diabetes may have stiff joints or cricoarytenoid joint involvement in patients with rheumatoid arthritis or vocal cord bowing seen in patients with Parkinson's disease. Now, what all tests should be advised to geriatric patients before taking them to surgery? We usually prefer to have all routine preoperative tests in geriatric patients because of physiopathological changes in various organ systems. Moreover, these tests may act as baseline investigation for future reference during perioperative period. However, apart routine tests, additional or special tests should be asked depending on the type or duration of surgery and associated comorbidities. Regarding optimization of these patients, most of the points are already covered in this lecture. The comorbid conditions of the patient posted for elective surgery should be optimized as far as possible for better results. Proper counseling regarding cessation of smoking, alcohol should be done. Encourage patients to increase their nutritional support and to maintain hydration. Most important is that chest physiotherapy like incentive spirometry, deep breathing exercises should be started preoperatively as these patients are at high risk of postoperative pulmonary complications. Next is how to obtain consent from these patients. However, the critical step in obtaining consent is an assessment of the patient's decision-making capacity. Because patients with cognitive impairment, even those with mild cognitive impairment may lack capacity for medical decision. There are 4 legal criteria for medical decision-making capacity. First is their ability to communicate treatment choice. Second is to understand the information communicated by the physician. Next is able to voice understanding of their medical condition, options for therapy, and outcomes. This can be better assessed by teach-back method, where we can ask patient to communicate back information about their diagnosis, treatment plan, and potential risk of treatment. Last is the ability to conduct a rational discussion regarding the treatment options. In case patient does not have capacity, treatment choices should be discussed with the patient surrogate with patient involvement as appropriate. Coming to pre-medication, as these patients are at risk of pulmonary aspiration, neutralization of stomach acid with non-particulate antacids can be helpful in preventing chemical pneumonitis and pulmonary injury in case aspiration does. Try and avoid sedative pre-medications or if necessary, use in low doses as these patients are very sensitive to these drugs and may cause respiratory depression. Most of the medications required to support various organ systems should be continued till day of surgery. However, drugs like antiplatelets, anticoagulants, NSAIDs, or OHA should be discontinued prior to surgery. Prolonged fasting should be avoided. In fact, encourage patients to take clear fluids up to 2 hours prior surgery to maintain hydration. Functional aids like glasses, hearing aids, dentures should remain in place until just before the induction of anesthesia. Coming to next section of the lecture, that is intraoperative management of geriatric patients posted for surgery. I'll be discussing different types of anesthesia like regional and general anesthesia, monitored anesthesia care in respect to geriatric patients, as well as intraoperative monitoring and care of these patients. First is regional anesthesia. It is covered under following headings, that is the technique, its effect, limitations, and advantages of regional anesthesia. It is technically difficult to perform neuraxial block in older patients, as positioning of geriatric patients is challenging because of dorsal kyphosis or arthritic changes which make difficult to flex hip and knee joints. Moreover, spinal and epidural needle placement is difficult because of calcification of ligamentum flavum and also because of decreased intervertebral space with age due to presence of osteophytes. Hence, a paramedian or lateral needle approach to epidural or subarachnoid space is recommended to avoid issues caused by midline ligament calcification. It is better to approach L5S1 interspace to overcome issues caused by distortion of dorsal vertebrae, as it is typically the largest intervertebral space. Increased block height after spinal and epidural anesthesia is seen in these patients due to age-related anatomical changes, which we have already discussed in last lecture, and also due to increased sensitivity of nerves to drugs given neuraxially. Moreover, clearance of local anesthetics also decreased with age. Hence, those requirements for spinal and epidural block decreased with age. Other limitations are increased incidence of hypotension and bradycardia after neuraxial block are seen, especially in patients with limited cardiac reserve. There is increased risk of local anesthetic toxicity after peripheral nerve block in older patients. Overuse of sedation in uncooperative patients under regional anesthesia may cause respiratory depression or increases risk of postoperative cognitive impairment, which negate the very purpose of regional anesthesia. However, regional anesthesia is still preferred over general anesthesia because it does not require instrumentation of the airway and allows patients to maintain their own airway and level of pulmonary function. Thus, it avoids all the complications associated with airway like difficult ventilation, intubation, pulmonary aspiration, and pneumonia. It also decreases the incidence of post-operative cognitive dysfunction and post-operative delirium. Since regional anesthesia prevent post-operative inhibition of fibrinolysis, decreased incidence of post-operative deep vein thrombosis, and thromboembolism is reported after neuraxial block. Lastly, there is decreased blood loss in pelvic and lower extremity surgery done under regional anesthesia. Most of the points related to general anesthesia in geriatric patients have already been covered in last lecture or beginning of this lecture. To summarize, we should pre-oxygenate these patients before inducing general anesthesia because of decreased arterial oxygen tension and also due to decreased other pulmonary function with age. Difficult mask ventilation is anticipated in elderly edentulous patients or elderly patients with history of OSA. The various ways to improve mask ventilation are by leaving the patient's denture in place or by inserting an oral airway. Packing the cheeks with gauze sponges also improve mask ventilation. Inserting the inferior margin of small sized mask or Randall-Becker sausage mask between the gingiva of the mandible and the lower lip will also help. Tachycardia and hypertension during laryngoscopy and intubation in elderly patients with stripped ventricles and arteries could trigger MI and strokes. Hence, measures should be taken to prevent hemodynamic response to laryngoscopy in these patients. Avoid long-acting anesthetic drugs, and their doses need to be adjusted according to increased sensitivity and decreased metabolism, as discussed in lecture 1. The best is to start low and go slow. Next is monitored anesthesia care. The increased comorbidities in elderly patients, especially cardiorespiratory disease, is often the indication for monitored anesthesia care. The challenges faced when geriatric patients are under monitored anesthesia care are involuntary movements like age-related tremors or tremors due to disease like Parkinson's disease, uncooperative and agitated patients or patients with cognitive impairment. Many times positioning is also difficult due to chronic pain, arthritic changes in joints or due to orthopnea. Persistent cough in COPD patients also pose a problem. Hence, sedation should be used judiciously to maintain a balance while managing these challenges and to avoid respiratory depression. Apart routine monitoring, verbal communication is important in monitoring level of sedation and cardiorespiratory function. All geriatric patients, whether under regional or general anesthesia or monitored anesthesia care, should be monitored according to ASA standard monitoring. However, more vigilant monitoring is needed in this vulnerable age group. Monitoring depth of anesthesia can prevent overdose of anesthetic drugs. Similarly, neuromuscular monitoring decreases the risk of postoperative residual block, which is commonly seen in these patients. Temperature monitoring is also essential in all patients posted for surgery for more than 30 minutes, as these patients are prone to hypothermia. Urine output monitoring is crucial, as hypovolemia-induced AKI is common in geriatric patients. Invasive monitoring is depend upon functional status of the patient and nature of surgery. Like pediatric patients, all precautions should be taken to prevent hypothermia in these patients, like maintaining OT temperature, forced air warming or other devices, warm fluids, because hypothermia is associated with postoperative delirium, cardiac dysfunction, coagulopathy, increased oxygen consumption, and poor wound healing. Due to decreased subcutaneous fat and loss of muscle mass with age, make these patients vulnerable for pressure and nerve injuries. Hence, proper padding of pressure points is necessary. Moreover, adjustment due to limitations in joint flexibility, position should be done. Position should be adjusted with the help of rolled sheets, pillow, or cotton pads to make patients comfortable and also to avoid injuries. Coming to last part of the lecture, that is post-operative management of geriatric patients. Are not only on the basis of duration or invasiveness of surgery, but also due to presence of comorbidities and general physical condition, these patients should be shifted to post-operatively either to recovery room, HDU, or ICU. The common post-operative complications seen in these patients are pulmonary complications, Postoperative hypoxemia, which is due to high incidence of postoperative residual neuromuscular blockade, atelectasis, respiratory depression caused by opioids and other anesthetic agents. Elderly patients are also at high risk of pulmonary aspiration and infection like pulmonary pneumonia. It is always better to optimize pulmonary status preoperatively, especially in patients with pre-existing pulmonary dysfunction or patient posted for major abdominal surgery. Furthermore, these exercises like deep breathing exercises, incentive spirometry, chest physiotherapy should be started as early as possible in post-operative period. Effective pain control with multimodal analgesia will also help in preventing pulmonary complications. To treat postoperative hypoxemia, titrated oxygen therapy should be used, especially in patients in COPD patients. Next common complication is perioperative neurocognitive disorders, and the most concerning is postoperative delirium. The new nomenclature used for POCD are delayed neurocognitive recovery and mild and major neurocognitive disorder. Postoperative delirium is defined as an acute alteration of mental state. It is clinically characterized by inattention, cognitive disturbance, or reduced awareness. It has a fluctuating course. Postoperative delirium is the delirium which occurs in hospital up to 1 week post-procedure or until discharge, and it should meet the Diagnostic and Statistical Manual for Mental Disorders version 5 diagnostic criteria. POD is seen in 10% of older postoperative patients and about 60 to 80% of ICU patients. And the most widely used and validated postoperative delirium screening tools are confusion assessment method and CM-ICU method for ventilated ICU patients. Postoperative delirium can be prevented by avoiding or limiting deliriogenic medications. Ideally, we should avoid all medication as per Beer's criteria, especially like benzodiazepines, anticholinergics, and antipsychotics. It can also be prevented or treated by modifying risk factors like by reducing sleep deprivation, increasing mobility, giving patients their glasses and hearing aids, ensuring good hydration and good pain control. Identify and treat cause of delirium like electrolyte imbalances, infections, hypoglycemia, urinary retention, and fecal infection. Pharmacological interventions should be reserved for agitated, delirious patients when other interventions have failed and the patient poses substantial harm to themselves and others, because these drugs may mask rather than treat delirium. Drug of choice is haloperidol, started at 0.5 to 1 milligram IV or IM. Other alternate drugs are dexmedetomidine, risperidone, olanzapine, and ziprasidone. The next postoperative concern is adequate pain management. It should be clear in mind that perception of pain is not obtended in geriatric patients. However, these patients have increased tolerance to pain. The added advantages of good pain control are it avoids cardiorespiratory complications, helps in early mobilization and return to daily activity. It also prevents delirium and postoperative morbidity. It decreases postoperative morbidity. The commonly used pain assessment scales in geriatric patients are same as used in adults, like visual analog scale, verbal and numeric pain intensity scale, or FACES scale. However, observational and behavioral scales are advised in patients with cognitive dysfunction. For postoperative pain management, multimodal therapy are suggested to provide superior analgesia and physiological benefits. However, opioid-sparing analgesic strategies should be preferred to prevent respiratory depression and also to prevent delirium. Non-pharmacological measures can also be used to alleviate pain in elderly patients, such as supportive communication, soothing touch, topical cold or heat therapy, physical therapy like sprinting. Among analgesics, paracetamol should be considered as first-line therapy for mild to moderate pain. Moreover, it is safe to use in elderly patients. However, NSAIDs should be used with cautious at the lowest possible dose. As I said earlier, opioids for postoperative pain management should be used cautiously for moderate to severe pain only. Regional anesthesia should be used wherever appropriate. It provides good analgesia. Moreover, the local anesthetic used in regional anesthesia possesses greatest opioid sparing capacity. Next is adverse cardiac events like myocardial ischemia and arrhythmias. According to the revised Goldman Cardiac Risk Index, the risk of an adverse cardiac event is high in patients who possesses 3 or more risk factors. Hence, these patients are vulnerable for cardiac events. All the more, myocardial ischemia in postoperative patient is rarely accompanied by chest pain. Secondly, to the fact that patients are still emerging from anesthesia and are also still under the influence of residual analgesic effects. Atrial fibrillation is the most common arrhythmia following major non-cardiac surgery. To avoid these cardiac events, oxygen demand should be decreased by maintaining normothermia and good pain control, and at the same time increasing oxygen supply with the supplemental oxygen and avoiding hypotension and severe anemia. Other complications are hypothermia, shivering, postoperative UTI or urinary retention, pressure ulcers, falls. The incidence of postoperative fall is high among elderly patients. It is maybe due to because patients is under effects of medications or have altered mental status, frequent toileting, previous history of falls, or visual impairment. To prevent fall, we should follow universal fall precautions, like bed should be in low position and locked, floor should be clean and dry always, bathroom should be fitted with handrails, adequate lighting, especially at night time, keep personal possessions within reach of the patients, and footwear should be well fitted and non-slippery. These are the various references. Thank you.